Hey doc, this is Michaela's case. Deep bites like this are challenging for even wire bracket orthodontics. But this is the way you would handle the case. Luckily, she has youth on her side. But she's definitely entrapped. I mean, we can see how much she's contacting the facial surfaces of her lower incisors. So from a nathologic perspective, this is definitely a case that will serve her well to improve biomechanically in addition to aesthetically. But with all deep bite cases, there's a couple different ways to handle it. One is really overexpressing the intrusion of the lower anterior teeth and I added this button right here, and adding reciprocating buttons that will counteract the intrusive force on the anterior teeth. As we intrude these teeth, there's a reciprocating force posteriorly that, if not accounted for, would basically cause the trays to seat down, come off the teeth. Yeah. So we want to put this kind of attachment here. This is a 4mm horizontal attachment, and I beveled it so that there is an extrusive counter force here. So you don't want the attachment right here to be parallel. You don't want this face to be parallel to the tooth, otherwise the tray would just come off. Essentially, you're looking at the lingual surface of the tooth. So you want to make sure that when the tray is seated, that it's not going to come off the tooth. So you have to look at the lingual undercut and make sure that the facial surface of the attachment is not parallel to that. So you want to have almost an acute angle so the tray is seated. It doesn't help to put the attachment on the second molar because the distance from the intrusive force all the way posteriorly, you're not going to get extrusion of this tooth. You can put an attachment to help it seat better. I often do that. But if you want to program any extrusion of these posterior teeth, which is something you want to do, you don't want to program any here. You can do intrusion because the tray will push down, but it won't pull up that far back from the fulcrum, which is the point at which you go from intrusion to extrusion. So something like this. I tend to put them just past the blue dot point, so 0.6, 0.7, somewhere in there. I have found that to be predictable for most patients. So I would probably dial this back just a little. This tooth here has extrusion. I'll probably bring that back just a tad. This is the tooth at which I'm hoping to not extrude or intrude. The way to tell is to go to the tooth movement table. Click on number 27. This would be, let's see, the lower. This is 0.7 millimeters of intrusion, which is what I want. And then we've programmed quite a bit more of the intrusion in the area of the incisors. You'll want to put an attachment here. Program some extrusion. Something like that. Something like that. You can replace the optimized attachment and place your own attachment, but this optimized attachment is made for it's an optimized retention attachment. That's the first time I've seen that. It's not too uncommon that Invisalign will produce new buttons. But what they're saying is they want to retain the tray on the teeth as you intrude the lower interiors. Likewise, you're going to want to do the same on the upper, over program the upper anterior teeth, put some buttons back here, do some relative extrusion. The extrusion does two things. It helps to anchor the intrusive force of the anterior teeth, but the more we extrude the back teeth, the more we can resolve the anterior deep bite. Likewise, if we upright these teeth, right now they're very lingually tipped. And do something like this. And do the same on the other side. That tipping, anytime we tip teeth, we in essence, or I guess posterior teeth, when we tip them buccally, we actually extrude them. It's kind of a relative extrusion. It's not a straight extrusive force, but the cusp tips are higher than they would be if they were lingually tipped. So one way to resolve open bite cases is to tip them lingually, thereby intruding those posterior teeth to some degree to resolve the anterior open bite. Likewise, or contrary here, we want to upright the teeth, which also helps the airway, but it helps us further resolve the deep bite situation. These are a lot of movements on the teeth. This is a case you might want to do 10 to 12 days per tray. You know, these are small rotations of anterior teeth or small tipping of, lower crowding, for example, we can get away with 6 days, 7 days per tray. These are complex movements, multiplanar, meaning we're moving the teeth in multiple directions. You want to make sure that the case is handled accordingly with the number of days that the patient would wear the tray. Lastly, this is a great V-Pro case. Lots of chewing on chewies, as many times as she can a day. How well the tray is seated vertically will directly impact how well this case is resolved. We could consider doing some propel or microosseous perforations in between the teeth to further help intrusion. I haven't found patients to be super excited about this. It's hard to charge for it. It's a lot of time. You got to numb the patient. Although I think it's a wonderful tool, it's one at which is harder to do practically. With that said, if she's one of those patients that's willing to go the long haul, that would definitely be a potential solution. Lastly, she's class 2 on the right side. I would say let's fix the anterior entrapment, uncouple the front teeth. Another way to say it is uncoupling or decoupling, and then see if her mandible drops down and forward and corrects this right side class 2. She's class 1 on the left side, but class 2 on the right. Whenever we have a discrepancy there, the midline should be off. You can see that they're resolving the midline as they intrude it, but just know that her midline is most likely not going to be perfect in the end unless we get class 2 resolution. Set her up for the idea of maybe using elastics to decrease the overjet in our second and or third round of trays. This is definitely a 2-year case to do well because of the increased amount of time that we need to move all of these posterior teeth accordingly. With that said, you can get a really good improvement in a year. So really just managing those patients' expectations accordingly would be helpful. And I do love the bite ramps here. We did talk about lingual attachments. I'm not sure, or you had mentioned lingual attachments. I would just do the bite turbos here. These are not attachments on the teeth. They're just bumps on the trays that allow her muscles to provide an intrusive force of the anterior teeth in this area. That's what they call bite turbos. Bite turbos come from bracket and wire orthodontics, where they would actually put composite on the linguals to act as the intrusive force. Can we put lingual attachments to help the trays seat better, to help procline these teeth? Yes, but I feel like that might be overkill in this case. I think you're on the right path if you just follow what we had previously talked about. All right, go ahead and get that all set up. Let me know when it's done. I'll take a peek and we'll go from there. Later, bud.